Oops. Okay. Can you guys hear me? Okay, thank you. I saw a thumbs up. My apologies. I had a meeting with somebody from your school. Apparently I get paid for doing this job. But I didn't fill out the right paperwork and it was echoey. So I accidentally signed off. So there will be 2 videos posted, part 1 and part 2, just so you know. So, okay, we are back. All right. Let's see here. Let me just share my screen with you guys. We're gonna start. I want to share this one. As let's go through this one first. Okay, so where did we stopped with Austin telling us the breakdown of everything, right? So we did that. Okay, so we're left there. Let me just go down real quick to make sure we hit all those points, because there's some things I want to interject off of what my outline here. So we started with the PowerPoint. We talked about age. The normal age is usually around college time, between around 20 and 30, which doesn't mean, and this is why I try not to get, oh my God, so super specific all the time, is because if someone doesn't go to college, that doesn't mean they're not gonna maybe get schizophrenia. So but I link that with it because that is a very common cause with what we see. We talked about the spectrums, video trauma for seeking treatment. We talked about that, and medication compliance. Now, they came out with some new medications. We're going to talk about one in particular. You can write it down if you want. We will talk more about it. It is going to be something you will be tested on or quizzed on or something at some point. It's called Invega, INVEGA. Should probably just put that in the chat. Why can't I ever pull up the chat? There it is. I'll just write it for you guys here. Invega. So that is an important thing. So can somebody tell me, why do you think if we have a patient who's non-compliant, based off of their own unfortunate psychosis, they're not trying to be a bad patient, they're scared or paranoid or for whatever reason, why do you think an injection would be a good idea if it lasts for either 1 month or 3 months? Why might that be better?
There's no issue of compliance like on a daily basis.
Right, exactly. It's kind of, we're all nurses. It's like birth control, right? Some people get depo, or they do because they don't want to take a pill every day, or the ring, or whatever they have out there in the world today. But it helps with compliance, just so they don't have to think about it, right? And convenience. This is a little bit different, but it kind of goes along those lines. So there is a medication. They actually just came out with another one. I'd rather, Invega is probably the most popular one that I see. They have 2 kinds. They have one, so it's a deep muscle medication. Well, it's IM. So they have one that lasts for 1 month, and then they have a new one that they made that lasts for 3 months. Of course, there is that portion of getting them in to get the injection, and having it, and we don't really, it's going to take too long to really get into how to do that. But usually, and that's why I put this medication down here. So I wrote Invega, I wrote a couple things down here. I wrote Invega somewhere else, but usually Abilify is kind of, they're not the same medication, but usually in the hospital, they'll start a patient on Abilify, get them stable, and then get Invega in their body before they go and they leave. That way it's in there. And then they have them come back. So hopefully the psychosis is under control. That's kind of like the hopeful, perfect scenario, right? And that would make sense. I would hope. So I do want to mention that because of the non-compliance. I think it's wonderful that we have these types of medications. In the very beginning, I can't remember how much it was, but it was so expensive but now they're seeing the efficacy. And once you start to see efficacy in medications, guess who doesn't have to pay as much out of their pocket? Insurance. So they're going to lower that rate because it's first like, we're not paying this. We're only going to cover this because maybe they don't know. But then they see, oh my God, wow, they're not going to the hospital every 6 months. And it's who's saving money then at that point? Rather put the money up front than having to keep doing this over and over and over again. And it's better for the patient, but I don't know if anyone works for insurance, but not my favorite people to deal with, if you will. I'm recording, right? Did I press record? I did, right? Okay, thank you. Okay. All right, we talked about age, interaction with certain behaviors when you are in clinical. We talked about that because certain things that you will see in clinical. There's going to be potentially more, but we did a couple examples, which is very good. We talked about all that. The medication compliance is where we just ended. Specific medications, more can be added, of course, because your patient more than likely is going to be on more than just an antipsychotic. Maybe they have something else going on where they're on other medications that are either mental health medications or they're on medications for hyperlipidemia and whatnot, and you're about to learn why, because of the side effects. So there's, I would say, 4 main things, and they're all important. 2 are probably, in my opinion, the most important. So we know what neurotransmitter means. I'm getting to that, by the way. I'm just going down to make sure I didn't miss anything. Main dopamine, we know that the main neurotransmitter in schizophrenia is related to dopamine, but it's not the only one. The side effects, we talked about tardive dyskinesia, Parkinsonianism, NMS, which is neuroleptic malignant syndrome. This is the one, as I mentioned, this is extremely important. So if you had a priority question on a test, who are you going to see first? Somebody who is with a sitter. If you guys don't know what a sitter is, it's someone who will sit by your bed, watch to make sure that you're safe. And so would you see that patient first? And they're having SI, suicidal ideation, but has a sitter in place and says at this moment they don't feel like harming themselves, see this person, or this person. Almost every time it's going to be neuroleptic malignant syndrome, because, and I'm going to post a video because we're not going to have time to watch it, but I'm going to put it under resources. I highly recommend you watching it. This will definitely probably be on every quiz and test you take because it is so important. I'll give you just the little piece of it. What happens is that, and this is why it's so important to look at your patients and watch them, because they'll still have muscle rigidity, but how much are they having? If you have so much muscle rigidity and you're having so many, like your body can't move, do you think your lungs are going to be able to expand? I'm sorry, you guys. Hey, Madison, Chihuahua, come here. My apologies. I would mute, but I have to talk. Come here. Stop it. Here, eat this. Okay, so unfortunately, the lungs can't expand. So that muscle rigidity is, I'm going to have to hold. Okay, come here. Please stop. Come here. I think we just got something delivered. Come here. Oh, I'm sorry. I didn't mean to hurt you. God, now you're making me look bad. Okay. So if you're having, so when you have this, and you'll notice in the video, and they're short, I like short videos. If you haven't noticed, I'm trying not to give you so much to watch, but enough where you're really going to get something from it. Chills, fever, the muscle rigidity, which can look like tardive dyskinesia. So if you don't know this type of stuff, you may miss the malignant, the NMS, and then what happens? Or malignant you'll miss it, and they could potentially, you leave the room, you're not noticing it, and then they stop breathing and unfortunately can pass away. So this is very, very important to know the symptomology of it and not to just brush it off as, oh, they're just having Parkinsonianism. Well, they just started the med. Maybe they're not responding well to it. Maybe something's happening. There's too much. They were given too much. They're not, whatever. So that's very important. So please watch that video, because we're definitely not going to have time today, unless you guys want to stay here with me until 2. You're all, no, please, can we go now? We talked about what cogentin is. Cogentin, I spelled it right. So cogentin, it can help to offset the symptoms of Parkinsonianism, tardive dyskinesia. Again, I go hand in hand with those. Antipsychotics do another thing. So this is why it's really important to watch for the labs. So we're looking, what lab would we want to look at for agranulose? I can't say the word.
Would it be a white blood cells?
That's correct. Exactly. So, and this is in one of the videos as well. So there's 2 short 15-minute videos that I will post. I'm not going to make it homework. It's just going to be under resources, but I do highly recommend you watching them, because that's important too. Isn't that important? Don't you want to know, is your patient at risk for getting a lower immunity? What if you have a homeless patient? And not all people that have schizophrenia are homeless, but a large population of them are, and they choose to be, they want to be. It's not, they've been offered housing and this and that, but they want to be homeless. That's where they're comfortable. But it's also potentially setting them up to become sick, because they have less immunity and to be able to fight off certain things. So this is why we're watching, and also to monitor for their medication management and whatnot, and like what's going on. Because obviously if it's dropping too low, we need to do something different. Maybe they're on an older, so if you're on an old school medication for schizophrenia, which we'll talk about, again, more medications this next time, then you're going to notice more than like, not always, but more than likely more side effects. Now we've made newer ones that, I'm not saying you're not going to have side effects, because we all respond differently, but I will give you, again, I'm not going to give you list, but I'll probably give you 3 of each. So, you know, okay, there's these older ones, this one, and this is how we use them. But I still see some pretty old school ones used that work really well, but they usually will have more side effects for most people. So what is the main side effects of antipsychotics? Tardive dyskinesia, which is Parkinsonianism. Unfortunately, the neuroleptic malignant syndrome, that's not a side effect. That's like a, oh my God kind of thing. Like we need to really watch for this. This could potentially be deadly. Low white blood cell count. And then the last one is metabolic syndrome. I was going to do a video on this one. Did I do one? Honestly don't even remember. I think it's on the white blood cells, not this one. So metabolic syndrome has to do with, unfortunately, and again, more of the old school medications for antipsychotics, they do tend to cause weight gain, which is another reason for non-compliance. And think about that. If you gain weight, what happens? You could get hyperlipidemia, high blood pressure. So then it becomes even more, and then you have a patient who is non-compliant on their antipsychotics, then they're not taking their other medication. It can just become a problem on top of another problem on top of another. That's why when people say, oh, so you're just a psych nurse, it's like, well, yeah, but it's a lot. And you want to help your patient. You want your patient healthy. So we have to watch so every time they come in, we always do weight. We watch very closely to make sure. So if we need to make adjustments, we can, or hopefully do some lifestyle changes if they have if they're married, or who knows what their situation might be.
I have a question
too. And I heard someone had a question, but I might post this just for fun. What is your question?
Is the mechanism of the metabolic syndrome like hyperinsulinemia, or is it something more like behavioral, like increases in serotonin cause more like overeating or something like that?
The second one. Yes, very good. It's funny, when I was writing that down, I was like, I had to, because again, we're all human and we don't always think oh, what causes this? And I was like, someone's going to ask me that question. Make sure you know that. So it more has to do with your body responding to the medication. I do have a video on that, and it does explain it really, really well, and about why, and it's the medication specifically, and what it's doing to the dopamine, actually. So please watch that. I think it's interesting. Hopefully you will too. What is taking place in the brain? And look, look at all this stuff. I mean, we've already done all of this. We talked about marijuana. What's that link? The drug-induced psychosis. Why do we get drug-induced psychosis? Because dopamine rises when we use drugs. Okay, so we're going to keep it so simple. Do you remember earlier how I said sometimes it can be so difficult sometimes and a lot of symptoms, they layer upon each other, and it's like, is it schizophrenia? Are you bipolar? Are you manic? Like what? It can be very difficult to make a diagnosis. And especially with schizophrenia and bipolar disorder, because they do exhibit a lot of the same symptoms, especially when someone's manic, it can be really hard to tell. And you'll see that in clinical. So when they rewrote the last DSM, which is, as we know, the book with how we diagnose our patients with mental health disorders. So schizoaffective disorder it's a newer diagnosis. And this is how I explain it, because I like to keep it like, again, not simple, but very, very easy to understand. It's basically a mixture of symptomology of schizophrenia and bipolar disorder. That's what it is. So in a nutshell, it is schizophrenia and bipolar mixed together. However, not everyone's going to present the same. Some might show no depression, some might show mania. I mean, I don't like to get too far into it because I feel that gets confusing, but it is in there. We look at it and we go on those, how many of this have they had? Are they having, some might not have hallucinations, some might get manic, but then every once in a while have, I don't know. It's so mixed, but a lot of the time, I've only seen one patient that hasn't had hallucinations with schizoaffective, but you don't have to. And schizoaffective disorder, I would say now when I'm reading charts, is one of the most common diagnoses that I've seen. That and bipolar. They're not using schizophrenia as much anymore because they're noticing a lot of other symptoms on top of it. So if I asked you a question on a test, and I would say it more obviously worded better than this, but what is schizoaffective disorder? If I just asked you that, like what two mental health diagnoses, symptomology are similar or something like that, you would say what? Schizophrenia and bipolar disorder, because you're basically taking both of those symptomologies and somehow that person is exhibiting enough of those symptoms of each to get the diagnoses of schizoaffective disorder. Does that make sense? So it's a mixture of bipolar disorder and schizophrenia. And then they're having those symptoms. Sophie. Oh, you're on that thing, mute. Let me try to unmute you. Am I muting you? No, it just says ask to unmute. Or you can type it in the chat. Thank you. I don't think my mic is working. Okay, do you want to type your question? Feel free. And as you type, let me see if there's any. Okay, we already talked about positive versus negative symptoms. We know that an illusion is something that we can actually touch and feel, but what you're touching and you're mistaking it for what it is. So you think that your bowl of soup is a telephone. That was a horrible analogy. Or you think the telephone is a dog, because it has to be an actual thing, but you're mistaking it for something else, just as a reminder. And I'm keeping my chat up. Don't worry, Sophie. I'm going to answer your question. We know delusions are a false fixed belief, usually potentially having to do with the CIA, police, religion. But as I think it was Sophie that mentioned it about the medication. Excellent. Or I hope I got that right. So, and then we talked about negative symptoms versus positive symptoms. So when you take medication, when you're taking antipsychotics, are you taking them to help the positive or the negative symptoms? Antipsychotics.
Positive.
Positive.
Exactly. Very good. Because you're helping with the hallucinations, delusions, and illusions. You guys are, you're all going to get 100% on, I can feel that. You don't even need a study guide. Girl, please don't do that. So why injections? We talked about that. Unfortunately, a lot of relapses of medication. And okay, now the fun part. Okay, Christy.
Yes, I had a quick question. I was wondering, for psych meds, do you generally use the trade name instead of the generic name?
So I'm for me personally, I'm an all-arounder. On the NCLEX, they use, unless they changed it, they use generic. Unless they changed it.
Okay.
To be honest, I go back and forth. For half of the meds I know both the names, and for probably 3/4 of them, I know like both of them, and some of them I just know one of the name. But I like to know both. I think it's important, but it takes time.
Okay, thank you.
Of course. Okay. So there it is. All right. We got Sophie. Sophie, when referring to bipolar disorder and how its associated symptoms are seen in schizoaffective disorder, could these symptoms be specific? Good question. To bipolar 1 or 2 disorders, or both? All. So it can be both. Very good question. Again, see, and this is what happens because I know it. So sometimes I forget to say it. But so thank you for asking me these questions. So what Sophie's basically asking is, when I'm saying if you are diagnosed as having schizoaffective disorder, is it only, because there are 2 types of there's actually 4 types of bipolar, but we're only going to talk about 2 when we talk about bipolar. And is it only type 1 or type 2? And it's both of them. So it doesn't matter. It could be either or, and it can still be considered schizoaffective disorder. Does that make sense to everybody? Okay, very good question. I'm really glad you asked that. And you guys know, just for fun, the difference. So is type 1, now we're not going to get all into it. Is type 1 more depressive or manic? More depressive or more manic? And is type 2 more depressive or more manic?
I believe type 1 is more manic and type 2 is more depressive.
Correct. And we'll talk way more about that and what that means, and hypomania and all of that. Very good. So yes, that is exactly what schizoaffective. So it could be either or, bipolar 1 or bipolar 2 diagnoses. And that's why as we continue, it'll make, I think, a little bit more sense, like, wow. And when you interact with your patients, like, it is really hard to tell. It's really hard to tell sometimes. So I'm really glad that they made that diagnoses. Okay. I just listed a couple here for fun. So Haldol is older. We use it a lot. We use it a lot in the ER as well, in an injectable form to help with people who come in. It doesn't necessarily have to be somebody who is psychotic, but if maybe they're in a usually they're not in the best of their mind in the moment, and it helps to calm them down. And it can be given in an injectable form and just helps really, really quick. But Haldol can also be given as a medication to help treat in pill form for your schizophrenia. Abilify is newer, and that's the one that I mentioned that usually goes along with Invega. Now, do you need to remember that? No, I'm never going to ask you, well, what would you give before you give Invega? Because it doesn't necessarily have to be Abilify. I would never ask that. We're doing generalized stuff here. So right now, I am going to ask you to please note that Invega is an injection. You can have it to either last 1 month or 3 months, depending on which one you have. You should know that. You should know that Abilify is an antipsychotic. You don't need to know that it's new, old, the other name for it, just that it is an antipsychotic. You should know that Haldol is an antipsychotic and that Seroquel is an antipsychotic. Again, I'm going to give you when we talk about medications, but for right now, these three, I would like you to know that. And what I would also like you to take note is off-label, this one right here. Does anybody know what this is very often used? Well, maybe not very often, but at least in my field of addiction, we use this often for a certain something off-label. Does anyone know what it can be used off-label for? And this is important because you'll probably see this on the med search floor or many different places.
Just gonna take a guess. Is
Please.
it sleep?
Sleep. You are absolutely correct. It is used for sleep. A lot of medications can be used for many, many things. I'm giving the most prominent of what I've seen. And I'll give you a personal story. It makes me want to crawl out of my body. So I am an insomniac, and so they give you just a little bit. It's a much different dose from when we don't actually use it, to be honest, that often anymore for schizophrenia, just because we've noticed other medications just tend to work better. I see this more used. Looking at it, I'm like, did I spell that right? It doesn't look right, but I don't see another way to spell it. Yes, it's used at a very small dose. So when I say small dose, I would say the average dose is 25 to 50 milligrams. And for sleep. So just fun fact. And yes, you should know that Seroquel can be used off-label for sleep. So you should know Abilify is an antipsychotic, Haldol is an antipsychotic, Invega is an antipsychotic, and it's injectable form. It can last 1 month, depending on, which one you get, or 3 months. And that Seroquel is an antipsychotic and can be used off-label for sleep. Perfect. That's all I'm going to say. I'm not going to say anything else. Like Haldol can be pretty sedating. This is a side note. So sometimes you have to change medications, take less, and then add another one, and or take it at night. But we're not going to get into that. I think it's just important. So if you see it in the chart, that you know what it is. That's what I think is important. I will give you in a mini lecture as we finish up and wrap up schizophrenia next time, and it'll be a very short, concise, more about the medications, because I think today we've really gone over what it causes, behaviors, lingo, terms, treatments, side effects, things like that. The things that are really important things to look for that could potentially cause death, like the low WBCs and the neuroleptic malignant syndrome. We talked about why injections, just looking at the time. Oh my God, we're perfect. Okay. So the video, I'm going to put this on, again, the 2 online, so don't worry about that. We talked about word clang and salad. Oh, I don't need to post this. Hello, I'm doing a video. Forgot. So I'm not going to put, I was going to post this whole thing. Okay, so what is a B52? So this is actually a universal term. Every single psych place I've ever worked uses this lingo. I think so. This also you need to know. It's important. you will see it. I'm guarantee it. We call it okay, do not say this in front of the patient, but we call it a cocktail. Because it is, because you're like mixing things together. It's kind of like just an easy way to say it. Does anybody I'm just curious, obviously, well, okay, I'm telling you, never mind, because I wrote it. So I'm going to tell you what it is. So, okay, how about this? Why would we give a B52? So the first thing, what would we do? A patient is in distress. They're verbally getting aggressive. We're trying to use our de-escalation technique, right? Because we want, what is our very last resort is any type of restraint. Can medication be a restraint? That is something you need to know. Absolutely. So yes, medication is a B52 is considered a restraint. This is usually given on almost every single patient that enters into a lockdown facility. They are given this as a standing order unless they have any sort of allergy to any of these. And then they're given another type of cocktail. Just in case something goes down, what do you do? Call that, oh my God, so-and-so is like bashing their head into, you know, we got to be safe. So we have this on hand. Does anybody know, okay, so they're getting agitated, de-escalation's not working, it's been about 15 minutes, patient is trying to, they're kind of like, you know, going around the unit. At that point, to me, I'm seeing, okay, this is what I'm doing is not working. What the staff is doing is not working. I offer the patient, would you like to take some Ativan that's on your, and now that is not considered a medical, help me.
Restraint?
That is not considered me just giving them their PRN as needed Ativan. I can offer that. Let's just say they had it. Because it can help them calm down. Because maybe that's it. And they're like, actually, that sounds really good. That would really help. That could change the whole world right there. It may not. If it doesn't, unfortunately, we go to the next step and we let them know, like, these are your choices. I think choices are really good. I think with kids, with human beings, with those who are potentially in crisis, I think choices tend to help people because they feel some control in it. This is what I've seen, and this is what I've learned over the years. At this point, a B52, and especially if you have history with the patient and like you kind of know, I mean, we can't guess, but you know what potentially might happen. And we usually know who is violent. You really have to gauge that, but you know, once you've been trained enough and been on the floor, even if it's not going to happen, it could happen, right? I'm going to be safe. I'm not going to kill them with this. And some people will actually ask for it. Now, if they ask for it and they come up to you really calm, don't give it to them. They're seeking drugs. But some people, you can physically, somatically, do you guys know what somatic means? It's going to go on your flashcards eventually. Somatic is like physically, like somatic, for example, somatic symptom of anxiety would be sweating, upset stomach, maybe talking really fast. So somatic symptom is how your body is reacting to, they call it I don't like this word, psychosomatic. So it's how your brain is reacting and then your body is reacting physically to that. So I'm going to give you the exact amounts of what's in each of these, but I wanted to see if you guys knew just for fun. So this is a cocktail. Again, don't say that in front of any medical professional, okay? Because that's kind of like a nerd. Just don't do it, please. It's kind of not disrespectful, but what if somebody's there for like, it's just not. So a B52, what is this? So Haldol is an antipsychotic and it is sedating. So does anybody happen to know how many milligrams is and this is an injection that we give, and I'll tell you how we give it. Does anybody happen to know? If you don't, I don't expect you to know unless you've been in clinical, which you haven't. 5 milligrams. So 5 milligrams of Ativan or Haldol, my apologies, which is an antipsychotic, right, guys? 2 milligrams 2 milligrams of Ativan. What is Ativan? What is the classification of Ativan? Not a benzo, but what is the classification? It's an anti what?
Anxiety?
Exactly. And then specifically, it's a benzodiazepine. Very good. Because not all, so all benzos are anti-anxiety, but not all anti-anxiety are benzos. We'll learn more about that later. Very good. And Benadryl, we already know, is an
Histamine,
often used off-label for,
sleep.
yes. So obviously it makes you sleepy, right? And if we're giving it as an injection, do we all know if we do something injection or IV, is it going to hit you faster?
Yes.
Yes, 50 milligrams. So this is a medical restraint called the B52. Benadryl is put in its own, I'm not going to test you on this, by the way. I may ask you what a B52 is. So know what a B52 is. It's 5 milligrams of Haldol, 2 milligrams of Ativan, and 50 milligrams of Benadryl given in an injectable form. I will not ask you what's in what syringe. But why? Because you're going to look hecka smart when you're on the floor and they're like, do you know what a B52 is? And you're like, actually, I do. It's a wonderful feeling. So Benadryl they put by itself in one syringe. So it can be pretty traumatizing for the patient too, but they feel I've seen it, they tend to feel so much better. The staff takes them into a private area because they need to expose, right? Because they give it in the bottom area, not on the top area. And they give it at the same time. So, and they've got this down. They really do, from what I've seen everywhere that I've been, they do a really good job at getting it done quick, and then the patient, it's fast. And there's usually a secondary order just in case this doesn't work, just as a side note. So Benadryl's in its own syringe, and that is why. Why do you think about why? So we all know that we like to mix medications if we're giving an injection, because we don't want to poke the patient twice, right? We know that. Just like with insulin, right? If we can mix it, might as well mix it rather than having to stick them with a needle twice. We all agree with that. But there's a different reason why we do it here. It would be great if we could put it all in one. But does anyone just want to take a wild guess why we put Haldol and Ativan together and put Benadryl somewhere else? Why can't they be put together? There must be some reason. Yes, Paulina.
I'm just gonna take a wild guess, probably very wrong, but because maybe the Haldol and Ativan are such small amounts and the Benadryl is a much larger amount, so you might not get the full amount if you mix it. So first of all, that is not correct, but that is a damn good, that is a really good critical thinking guess. And I know I'm smiling even though you didn't get the answer correct, but because do you see how she thought about that? That makes so much sense. And I never even thought about that. That's very, very smart. Contraindications. So, and I'll be very honest with you. Again, I am not perfect. I don't remember which one can't be. I don't know which one has a contraindication, Ativan and Benadryl or Haldol and Benadryl. I just know because again, my brain is only so big, right? I can only squish so much in there. So basically Haldol and Ativan get put together because one of them has a contraindication to be mixed with Benadryl. Now you can give it together, like one on each side of your body, but it cannot be mixed together. Very good guess though. Good critical thinker. Where's our mascot? Is he nap time or what? I'm not sure. He's with his grandma.
Okay. You're like, I'm trying to be in school. Okay, we're almost done, guys. You guys have done so well. I'm very impressed and happy. Okay, we did word clang. So what's the difference between word clang versus word salad? Someone who hasn't talked yet?
Word cling has rhythm or rhyming or repetition to it.
Mm-hmm. Beautiful. And word salad is just kind of It's not really a term. Don't do that in clinical. But it's just words that don't have repetition and don't really go together. Excellent job. Medication, again, not all disorders does this have to be, but I've never met anybody who has schizophrenia who has not been successful, who has not been on an antipsychotic. I'm just giving you the information. Please, if you have, please email me or let me know, because I am very interested. It just has to do with the chemical imbalance in the brain, and it doesn't fix itself, like depression sometimes, can and whatnot. So I do want to mention that. Other meds to manage symptoms, we already talked about that. They could have another diagnosis, they could have whatnot. It doesn't just have to be antipsychotic. That's all you can do, right? It can be other things. And then hopefully the hope is when someone is hospitalized, they're put on a 5150, then it's extended to a 5250, but they're only there for an extra 10 days, let's say. They don't have to stay 14 days. If the physician or NP or whomever feels that they're able to go home, they can go home. Hopefully they'll do some type of therapy, some type of aftercare, coordination of care, right? That's our hope. That's what we want. And that they become stabilized. Okay, we're going to do one NCLEX question and then we're done. Does anyone have any questions? And I will put the videos up and everything. And we'll finish right on time. 11:45, right? That's us? Yeah. Okay, perfect. I appreciate you guys. I know this can be long sometimes. Like I said, sometimes it'll be long, sometimes it won't. It just, we go with the flow. What are we doing? Oh, the question. So we're not going to do the top one because it has nothing to do with schizophrenia. And we don't have time otherwise. I was just gonna, again, always have something to do. Okay. This is a perfect question because we talked about this today. So I'm going to do a couple things because we have the exact amount of time. I'm going to explain the question, kind of start to help. Oh, did I not share it? I didn't share it, did I? Someone just said something on the chat. Yeah. Thank you. Thank you. Thank you. I need someone. I need help. I forget simple things. There we go. Thank you so much for letting me know. Okay. Can you see it? Good. Okay. Thank you so much. Okay. So we're going to do this question and you'll see kind of how I do work through the question. Okay. So number 2, the teenage client in the adolescent psychiatric unit asked the RN, "Do you hear those voices? They sound so frightening. Which of the following responses by the nurse would be most appropriate?" So before I even look at the answer choices, and this is just tips and tricks, like I told you, I've worked for Kaplan, so I try to give you little bits and pieces here and there. Just why not? We're here, might as well learn, and we've got 5 minutes left. Let's learn something, hopefully. So I'm gonna look. First thing I like to look at is age, because age matters, doesn't it? If you have a 6-month-old versus a 10-year-old versus a 50-year-old, that can matter, right? Stages of development, all sorts of things. So it's a teenage client and they are in a psychiatric unit. I like to know where they are or what procedure they may have had, right? I like to build a picture and I like to not go off of that path because I am one of those. I will build a whole story that doesn't even exist in the question. Don't do that because that's not what they're asking. And what is happening to this? It's a girl, I believe, or maybe it doesn't say, this young adolescent patient. Do you hear those voices? They're having auditory hallucinations. And the patient is saying that they're frightening. They're frightening to the patient. Okay, that's very good information for me to know. So now I can paint a picture of what's going on. Now, one of the most important things is, what is the question actually asking me? It's asking me, for me as the RN, what is the most appropriate thing for me to say back to this patient? This is a therapeutic communication question, but you can't answer the question without knowing about schizophrenia or psychosis, right? But now you do. So now we can probably answer this correctly. And if you don't, that's fine too. You're going to do thousands of these before you take your NCLEX, right? Right. Okay. So number one, the voices, what am I going to say to, okay, we know where we are. So number one, the voices around here sound friendly to me. I usually don't like to like nix questions right off the bat, but would you say that? Is that therapeutic? Are you addressing this young adolescent's something that's going on with them? You're not. So I'm pretty much nixing it, but I usually don't do that right off the bat. Number two, are they men's voices or women's voices? That's not a bad question. However, I'm going to hold on to it because I don't know what else is going on, because that will probably come up. I want to know that maybe, but later, right? That may not be the first thing I want to say, because what am I doing? I'm feeding into it. Maybe later I want to know because I want to know more about what's going on inside those auditory hallucinations. But let's see what else we have. What do we have to work with? Number three, I do not hear anyone, but I understand why that would scare you. Okay, so the only thing I don't like about this question, and we're not really supposed to do this, I understand. Because it's kind of belittling a little bit. Do you understand? I love it. Good job. You guys passed the test, because that's not what she's doing here. Or he or she, we can all be nurses. What she's saying, or sorry, what he's saying, this is a male nurse. I do not hear anyone. So giving a fact, I don't hear anyone, but I can understand why that would scare you. This is okay to say. Now, if someone had cancer, and I don't feel like I need to get into it, but do you understand when it's appropriate to say, I understand? Because it can be belittling to patients when we say that. Oh, I understand why you're scared that you have breast cancer and your husband might not be attracted to you anymore. The hell you do? I'm saying that because I've heard a patient say that to somebody, right? So in this instance, and we have to kind of look what makes the most sense. Would you rather say, we know number one, we're not going to say. Number two, would we rather ask number two or number three? Number three, right? Because it's most therapeutic and you're opening up hopefully for conversation. Number four, come on. Now I always say distract, but is this, I mean, we're totally disregarding this poor young adolescent patient. Let's turn up the volume of the music and so we can distract you. It's basically saying, I don't really have time to deal with you. Let's turn this up and go do something else, right? We can all agree on that. So we definitely know number one and four aren't correct. For number two and number three, what is the most correct is number three. And then number two, we might do later. Does everybody understand why? This is a pretty, and by the way, these are all passing RN Kaplan questions. So you just passed your NCLEX with one question so far. And I will post NCLEX questions, get posted under NCLEX questions, because some of these questions might show up on a test or a quiz. Just so you know. Any questions about that? We're done. 11:45. Oh my God, I've never landed like right on the time. But ask questions if you have questions. Did you learn a lot? I hopefully, and did it stick? Thank you. I think that's Kevin. Is that okay? Thank you. I hope so. I was hoping the first day is always kind of odd. But the second time I'm hoping like the solidification starts to go together. So keep up on your homework. You guys are doing so well. Thank you again so much for the effort that you're putting in. I can tell you're not just like, whatever, get this over with. You guys like are doing a really good job. So thank you so much. I'm so excited to meet you in person. I will let you know where to go. We're going to watch a movie that is mental health based, but amazing. I'll post everything and you guys are free to leave me. And I will post both of the recordings up as well. So all of that will be done today. And I will be in contact soon where we will meet and the syllabus will be up soon. I'm working really hard to get that done. Okay. one chat, and then if you're done, you feel free to sign off, but I want to answer for people's reference. Haldol is one of the, it is, oh, yay. Haldol, thank you. Is the one that's not compatible. Someone told me that once and I forgot. How can I remember that? Haldol, Ativan. I'm just gonna remember that because I'm gonna think I like taking Ativan on its own. I don't know. Just remember it. If someone can think of a mnemonic, hell no, you can't. Oh, I love it. Good job, Paige. Yes. Hell no, you can't miss it. I'll never forget it. And thank you so much for looking that up. I really appreciate that. Awesome. So now I won't, again, I'm not going to test you on it, but I'm glad that you know that now. Awesome. Beautiful job. All right, guys, have a wonderful day. And I will see you next Tuesday. I'll come a little bit early, of course, to set up things. If somebody like can bring that disc player, that would be great. Forgot my apologies who offered, and I may just buy it. We'll see. I'll let you know, and I'll see you next week. Remember, you have to kick me off, or I won't leave. I'll just keep talking. So
Thank you.
Thank you.
Thank you so much, guys. Have a great day.
Thank you.
I just, I have a quick question, if you can maybe just answer it right now, Miss Amanda.
First, did you want me to record or unrecord?
If you want to. It's class related content.
Yeah.
So, you know, like before you got to the NCLEX question, you were talking about how, you know, like how like a clinician can discharge a patient. How would the procedure work for getting a discharge, like through like the hearings? Because I do know like patients like in involuntary psych unit, they do have hearings, or
Yes.
they can have hearings.
Yes.
Sometimes for lack of a better term, the judge can say, okay, you're fine, you can go, well, or something like that.
You're correct. What is that called again? It starts with the C. They're
I
when someone else
forgot.
is making your decisions for you. I should have mentioned that today.
Conservatory.
Being conserved, exactly. So what is your question? How is it?
Yes. My question is like, how does the process work? Like, if you're a patient, because sometimes when I was working, I even had patients ask me, "Hey, I want a hearing," and I was like, I just had to defer to the nurse. So, how does that work? Like, you know, if I was the nurse.
So usually what different places have different, but the basis of normally what happens is the nurse then contacts the physician.
Okay.
I almost want to call it like an order. It's kind of like an order, but they have the right to do that, and they do contact whoever they're being conserved by, and then they have the right to meet with the judge. It's actually easier than one would think, in my opinion. Because that individual really could be like, I hate to bring up like all the media, but like, you know, Britney Spears, and we can all have our opinions. But like I have mine, and you know, you saw how probably that went down, but yeah, usually it goes to the nurse. You're all know I haven't. It goes to the nurse, physician, who they're being conserved by, and then it's basically set up that way. And usually they're appointed a judge that knows that patient, so that they can have that understanding and a better understanding to be able to make a better decision. And I'm so glad you brought that up. Darn it, I totally forgot to talk about. I'm going to make that part of maybe I'll write an announcement. Thank you for mentioning.
Gotcha. Yeah, because I would like to have a rundown of those rights, because sometimes like patients, they get very knowledgeable about the stuff very quickly. I'm surprised how knowledgeable they get so quickly. And you know, they'd ask me these questions, I'd be like, okay, I'm a nurse, not a lawyer.
Exactly. Yes. And it goes to the, how do you say, judicial, whatever, the judge system. It does. And
the judiciary.
Thank you. Exactly. I need an English class. It's like I can say some of the words so well, and I'm like, why can't I say this word? My tongue doesn't. I tell people I'm a second, English is my second language.
Oh,
Because
goodness.
whatever I'm speaking is not English. Excellent question. Thank you again for your participation. And I did record this because I think it's important. So actually we did cover it. It's on recording. Right?
All right.
So
Mhm.
you guys don't have the rest of the day class, right?
Yeah.
No more class today?
We
Oh, no,
have
later.
asynchronous work.
It's asynchronous today, so
Okay.
we do have class, but when we do it, it's totally up to us.
Oh, cool. Okay. Awesome. And other people go to work. Yeah. I'll be working too. And let me know if you guys need anything. A few of you have emailed and texted me. That's completely fine. And again, I will be in contact where you need to be on Tuesday so that there's no confusion. I hope I don't, I'm gonna get lost more than likely. So if I'm not there right at 9, I'm lost. So that's up to whoever's on here to let them know she's lost. Somebody help her, call her. Okay.
Fortunately, CSM is a pretty small campus and
Oh,
the
it
parking
is?
lot is like right by the building we go to. So it's not too bad.
Oh, it's like one building?
I'm assuming we're in the nursing building. We're always in the same building. So
Okay. All right. I think that's where we are. Thank you. All right.
yeah,
I'll be good. I'll make it. I'm a grown up, right?
you got this. We'll be there. You'll see us in our purple scrubs, or I guess we won't be wearing them, but you'll see us.
This isn't clinical. Yeah, no, you can wear what you want. Be comfy. I will be wearing scrubs because I will be going to work after, but be comfy and have a
We'll
wonderful.
find you then.
I'm noticeable. You'll see me.
Thank
All
you
right.
so much.
Thank you. I really appreciate you all. Have a great day.
You too.
All right.